Today, we're going to explore Marfan syndrome. It's a genetic disorder that subtly weakens the very framework holding our bodies together, and it often comes with some pretty serious, life-threatening consequences.
This is AMP Live Studio, and I am your host. I teach AMP as a registered nurse and as an anatomy and physiology instructor for advanced level healthcare professionals.
So here's our roadmap for today. We'll start off with a patient's story to ground us. Then we'll explore the body's structural framework, what's supposed to happen. After that, we'll get into the genetic flaw, see what goes wrong, and how that leads to clinical signs. And finally, we'll touch on diagnosis, management, and the overall impact on the body. Let's begin with a clinical scenario, because seeing how this condition presents in a real person makes it all click.
So, I want you to meet Pepe. She's 27 years old, a school teacher, and she's been feeling, well, just not right lately, which is what brought her to the clinic.
Now, when Pepe comes in, her symptoms might seem a little all over the place. She's always been extremely nearsighted, but now she's getting more and more tired and short of breath. During the exam, her doctor hears a heart murmur. And then there are the physical clues. She has a very tall, slender build with these strikingly long fingers. That's a sign we call arachnodactyly, which literally means spider fingers. It's this whole collection of clues that starts to point toward a single underlying issue.
Pepe's symptoms affecting her eyes, her heart, and her skeleton all point to a problem with one thing: the body's connective tissue. To really get what's going on, we have to understand what that tissue is supposed to do.
Okay, the star of our show today is a protein called fibrillin-1. It's a big glycoprotein that's made from instructions on the FBN1 gene, which lives on chromosome 15. The easiest way to think about fibrillin-1 is to picture it as a key part of the body's scaffolding. It helps form these tiny structures called microfibrils that provide support and structure to basically all of our tissues.
Now, fibrillin-1 is a real multitasker. It has two incredibly important jobs. First, there's the structural part. Its microfibrils act as a framework for elastin, giving tissues like our blood vessels their strength and ability to stretch. But it also has a regulatory job. It kind of grabs onto and stores a really powerful growth protein called TGF-beta, keeping it from being too active. This dual role is absolutely central to understanding Marfan syndrome.
So what exactly goes wrong in Marfan syndrome? Well, it all starts with a flaw in a single gene. You can think of it like a single structural thread in a piece of fabric beginning to unravel. Let's put these side by side. On the left, you got your healthy fibrillin-1. It makes strong microfibrils, it keeps TGF-beta under lock and key, and our tissues are strong and elastic. But on the right, when there's a mutation in that FBN1 gene, you get defective fibrillin-1. This creates weak microfibrils, and it also lets way too much TGF-beta run wild. The end result? Tissues start to lose their integrity.
This whole process is like a cascade, a domino effect. Just follow the flow here. It kicks off with that FBN1 mutation. That leads to a faulty fibrillin-1 protein. Because the protein is faulty, the microfibrils are weak. And since they're weak, they can't hang on to TGF-beta, so it becomes overactive. This excess TGF-beta then signals for more matrix-degrading enzymes, and the final outcome is widespread tissue weakness.
All right, so now we know what's happening on a molecular level. Let's connect this back to the signs and symptoms we saw in our patient, Pepe. Remember that overactive TGF-beta we just talked about? Well, in the skeleton, it actually promotes bone overgrowth. This is why people with Marfan syndrome often have that characteristic tall, slender build and those really long limbs and fingers. The weak connective tissue also leads to loose joints, which can cause other problems like a curved spine or flat feet.
The eyes are another system that takes a big hit. The tiny ligaments that hold the lens of the eye in place, they're made of fibrillin-1. So when they get weak, the lens can actually shift or dislocate. This is called ectopia lentis, and it's a huge red flag for Marfan syndrome. Patients also tend to be very nearsighted and have a higher risk for some serious issues like retinal detachment and glaucoma.
But the complications that we worry about the most are cardiovascular. The aorta, our body's main artery, is packed with elastic fibers that rely on fibrillin-1. When it's weak, the aorta can stretch and bulge, forming an aneurysm. This weakness can also affect the heart valves, which is what causes the murmur we heard in Pepe. But the biggest danger of all is something called an aortic dissection. The Mayo Clinic uses a really great analogy for this. They say an aortic dissection is like a weak spot in the wall of a tire. A small tear in the inner lining of the aorta lets blood blast its way into the wall, splitting the layers apart. This can lead to a complete rupture, and that's often fatal.
It's the main reason that unmanaged Marfan syndrome can be so dangerous. Okay, so knowing those serious risks, how do we diagnose Marfan syndrome and what can we do to manage it? The whole idea is to identify the condition early and then try to reinforce that weakened bodily framework. Because Marfan affects so many different parts of the body, there's no single simple test for it. Instead, clinicians use a kind of comprehensive checklist called the revised Ghent criteria. It involves looking for those major signs we talked about, like an enlarged aorta or a dislocated lens, and then combining that with a systemic score based on other physical features, genetic testing, and a really thorough family history.
When it comes to management, the goal is to protect the aorta, and the strategy is really two-pronged. On one hand, you have beta blockers. These work by reducing the physical stress on the aorta. They lower the heart rate and blood pressure. But then you have drugs called ARBs, like losartan. And these are really cool because they tackle the underlying problem by tamping down that excessive TGF-beta signaling.
And the evidence shows these medications really work. A big meta-analysis in 2022 found that both ARBs and beta blockers on their own can slow down how fast the aorta enlarges by about 50%. This is huge. It means that using these drugs, especially together, can be a really powerful way to protect the aorta. So let's wrap up by just recapping the broad, multi-system impact of this one faulty gene. Since fibrillin 1 is pretty much everywhere, the effects are widespread. For instance, weakness in the lung tissue can lead to a collapsed lung. In the skin, you might see stretch marks because of poor elasticity. It can even affect the central nervous system by causing the covering of the spinal cord to stretch out, a condition we call dural ectasia. So here's the whole story, from the gene all the way to the clinic. You start with normal fibrillin 1, doing its two jobs, providing structure and regulating growth. A mutation in one gene messes all that up, starting a chain reaction. This molecular problem then shows up as a systemic weakness in the body's tissues. And so, our treatments make perfect sense. They target both the physical stress and the faulty cell signaling.
Understanding a condition like Marfan syndrome is a powerful reminder of how much of our health depends on the perfect function of microscopic proteins. It's truly amazing. Stay pathocurious, and I'll see you in the next episode. And please remember, this presentation is for educational purposes only and is not intended as medical advice.